A continuación, nos honra la presencia del Dr. Adam Rodman. El profesor Rodman, actualmente profesor asistente de la Escuela de Medicina de Harvard y miembro del equipo de médico de Beth Israel Deaconess Medical Center, es un líder reconocido en el ámbito de la educación médica digital y el razonamiento clínico avanzado. Su contribución al desarrollo de currículos innovadores y la integración de tecnologías de inteligencia artificial en la formación médica lo posicionan como una figura destacada de la medicina interna moderna. Entre sus logros más notables destaca su rol como co-director del IMED, Innovation in Media and Education Delivery Initiative, desde donde ha liderado la transformación educativa, incorporando herramientas digitales para mejorar el aprendizaje médico. Bajo su dirección, la Conferencia Anual de Educación Médica Digital de Harvard ha reunido a expertos de todo el mundo, promoviendo prácticas de vanguardia en la enseñanza médica. El profesor Rodman ha sido reconocido múltiples veces por su excelencia en la enseñanza y liderazgo clínico. Ha recibido el ACP Humanist Medicine Award y ha sido nombrado Teacher of the Year por el Hospital Medicine Program in Beth Israel Deaconess Medical Center en más de una ocasión. Además, ha sido galardonado con el Harvard Medical School Mentorship Award, subrayando su compromiso en la formación de futuras generaciones de médicos. Su obra publicada incluye investigaciones pioneras en revistas de alto impacto, como lo es The Jornada American Medical Association, donde ha explorado el uso de modelos de inteligencia artificial en diagnósticos clínicos complejos, un área que tiene implicancias directas para el futuro de la medicina interna. Además, es editor asociado de New England Journal of Medicine, EA, reflejo de su profundo entendimiento y contribución al campo de la inteligencia artificial en la medicina. Su presentación se titula Hacia las segundas opiniones a través de la inteligencia artificial. Ahora damos con un fuerte aplauso la bienvenida al doctor Rodman.
Hola a todos, mi nombre es Adam Rodman, soy un
So I study clinical reasoning. One of the ironic things is that I am not an artificial intelligence researcher. My focus has always been on what happens up here. And one of the major themes today has been the effect of technology on semiology. So how technology has changed our approach. As has been said, we actually don't say semiology in the Anglo-Saxon world. Semiology, however, is a very old word. Semiotics, as someone who loves history, I'm going to say semiology. My focus of my research is not necessarily on semiology, but on clinical reasoning and how technology changes what happens up here. So this is what I'm going to talk about today. I'm very excited because I'm going to be joined by Dr. Carrillo for a part. So first, we are going to talk about our current understanding of clinical reasoning. Dr. Carrillo gave a wonderful overview on the education of clinical reasoning. I am going to talk about some of the research from a cognitive psychological perspective of what actually happens when we see patients. And then we're going to talk about why this matters. Dr. Carrillo already mentioned medical errors, diagnostic errors, which are one of the big reasons we care deeply about clinical reasoning. The next reason might be that computers are going to be increasingly doing that, so how do we work with them? And then I don't want to just talk to you. I want to show you how reasoning is affected by technology. So I am going to be joined again by Dr. Carrillo solving a mystery case live. He has not seen it before. And we are going to also use an artificial technology during the case so we can both compare and contrast the nature of human and machine clinical reasoning. The reason that I want to show this demonstration is we are then going to talk about the evidence. In the last 2 years, and I should say this is an old field, this field actually stretches back to 1959, but in the last 2 years there has been an explosion of both very exciting and very scary evidence. Medicine is changing rapidly to the point that I think a couple decades from now, it's going to be unrecognizable from how it is today. And then I'm going to talk a little bit about my own research, which is a field called human-computer interaction. The question is not how do humans reason, it is not how do computers reason, but how do we reason together? What what can we do well together? What can we not do well together? And then to really kind of answer this question, well, what should we be learning in medical school? Okay, so we're going to start with a simple question. It's actually a very complicated question. What is diagnosis? Dr. Carrillo showed an example from the National Academies of Medicine from the 2015 report of the diagnostic process. The short answer, though, is it's complicated. There's actually a wonderful study from about 15 years ago that took a number of experts in clinical reasoning and asked them, what does it mean to make a diagnosis? And they basically got 15 different answers. It is incredibly complicated. And I'm going to kind of explain why. So Dr. Carrillo mentioned at its most basic, diagnosis is a classification task. We have a nosology, so we have a classification scheme for disease. And what we have to do as physicians, as internists, is identify which of those diseases our patient has. And we use many different processes to do that. We use semiology. We take a clinical history. We order different diagnostic tests. And at the end, we hope that we can narrow it down to a single or multiple diseases, a differential diagnosis. Now, part of the process is that this is all mediated through the human mind. And I'm going to talk first about really the most revolutionary idea in clinical reasoning, what really started this field off, which is dual process theory. Dr. Carrillo, I'm both basically copying you, but to go off of Kahneman and Tversky, so in the 1970s, psychologists became aware that human beings actually have two different systems of clinical thought. We have our system one, that's our Homer Simpson here. System one is very fast, it is very efficient, it is based on shortcuts called heuristics. The classic example is everyone has driven home at some point. You've driven in a car, and you'll have these points where you just stop paying attention and 10 minutes can go by and you'll still have been driving. Why does that happen? There is a very fast, automated, efficient Mr. Spock over here is our system 2 thinking. System 2 is very slow, but it's also very deliberate, and it's acontextual. It is difficult to do system 2 thinking. When we talk about clinical reasoning, we're often talking about these system 2 processes. The classic studies from this come from the 1970s by Larry Elstein, actually at Harvard. Dr. Carrillo was talking about the abductive process. Abductivo, that word is used in Spanish. In English, we often talk about the hypothetico-deductive process, but they're the same thing. Imagine Sherlock Holmes. This is your classic example, or Dr. House from the TV show. The doctor is a detective who uses both inductive and deductive reasoning to solve problems. We collect information, make a differential, and then we test those different things on a differential as new information comes. So Dr. Elstein did some very famous experiments at Harvard in the late 1970s, where he sat down a group of medical students and he sat down a group of experienced attendings, and he gave them cases. What he found is that both the medical students and the attendings used the abductive process. Everyone acted like they were a detective. But what he found that was very curious, that didn't make a lot of sense to him, is even though both of them used the same appearance of reasoning, the attendings would only ask a few questions. They asked about a quarter of the questions of the medical students, and they were much more accurate in coming up with a diagnosis. So the medical students would ask many more questions in a hypothetical-deductive fashion, but come up with a less accurate answer. This was the first hint in the 1970s that something else was going on inside the human brain. And as we know now, this is the same image that Dr. Carrillo showed. What's happening is a very complex interplay between system 1 and system 2. So what happens inside the attending's brain, who has much more experience, is they have a much more refined system 1. So they are able to identify patterns much earlier in the presentation before switching into system 2 thinking to ask more focused questions. At some points, the attendings don't even use system 2. They may be able to get along just on system 1. Now, this is very theoretical. This image is very hard to understand, so I'm going to give a practical example from something that is called script theory. Script theory is an educational strategy that's based on dual process theory. So, how do doctors know what diagnosis that a patient has. So we get knowledge from the world in many different ways. We go to medical school. One of the most important things that we do. We read journal articles, and then we see our patients and learn from our patients and get feedback. All of this information gets stored in our brain. How does the brain store knowledge? So if you go back into the early 20th century, the assumption was that we stored knowledge kind of like the Dewey Decimal System, like knowledge in a library. But we know now that that is not true. And doctors in particular store knowledge in something called scripts. What is a script? A script is an exemplar of a disease state. So for example, my script for pneumonia might say, okay, it affects both children through older adults. It's usually subacute in onset. There are usually low-grade fevers, respiratory symptoms, and then I have senses of will it respond to antibiotics, how does the patient look? What does their respiratory exam look like? What do they sound like on auscultation? And all of this information is stored in this automated illness script. Now, one of the points of script theory is that scripts don't exist in isolation. They exist in schemas in our brain, by which I will identify one disease by excluding other diseases. This is one for shock here. And of course, because this is a system one process, it's a shortcut process, there are many ways that human beings can go wrong. We can have personal biases. We can have systemic biases. We see this all the time in the hospital. I'm a general internist. I work in the clinics and the wards. I do not work in the emergency room. So my experience of a pneumonia and my scripts for a pneumonia are very different than an emergency room doctor who is seeing much sicker patients, right? Usually the patients that I see with pneumonia are, if they're seeing me in clinic, they're not that ill. Whereas the script for someone who works in the emergency room, if you come to the emergency room, you're much sicker. So what happens when we see a patient? And everyone has this experience. So I'm sitting in clinic, a patient comes and see me. This woman says, I can't breathe, it started yesterday. I'm not even really having conscious thought. It's like when I'm on the highway and I stop paying attention when I'm driving. And in my head, I automatically convert these phrases into something called a problem representation. This activates the script in my head for something that I call acute dyspnea. And because this is acute dyspnea, I automatically activate a schema for how I think about people with shortness of breath. What happens? Well, it feeds back to my questions. So I'm not necessarily consciously going through a Sherlock Holmes process. And my next questions are going to be, well, have you been wheezing? Do you have a fever? Why? Because in my schema for acute dyspnea, I have a COPD exacerbation, an asthma exacerbation, a pulmonary embolism. And then I will, as I collect this information, I will further instantiate my problem representation. So now I have acute dyspnea with wheezing and without fever. And this process continues iteratively until I have a pretty good differential diagnosis. Now, what also can happen, of course, is that I can find something that doesn't fit. I can find something that confuses me. Something causes me to pause, and then I will switch into more system 2 thinking, where I may start to use inductive reasoning, so physiologic reasoning, where I may start to use probabilistic reasoning, looking at test characteristics, or many other forms of human reasoning. But in general, the way that we approach our patients mostly focuses on this system 1 process with these crossovers to system 2. So if we were to go back 10, 15 years ago, dual process theory was the most profound way we thought about clinical reasoning. However, psychologists have been busy really talking about other ways that humans reason, or that doctors, I should say, reason. So we have, of course, Homer Simpson here in his brain. But the reality is, think about your life on the wards. There's a lot of other things going on. So I use a pager in the United States. My pager goes off every 2 to 3 minutes. The hospital can be a very stressful environment. Sometimes it is 2 a.m. and I am only able to take care of patients because I have had 2 liters of coffee. I may not have slept very well, and there are many other colleagues that I interact with. I could be having a bad day. Maybe I got in a fight with my wife before I came to work. Maybe I'm having a wonderful day. And I can see the exact same patient, and if I see that patient at 10 a.m., I've had 2 cups of coffee, I'm having a great day, or I see that patient at 2 a.m., when I have been paged 10 times in the last 15 minutes, my mind is going to work differently. And this is the idea of ecological psychology. So dual process theory focuses only on the human mind. Ecological psychology posits that reasoning is a byproduct, not only, it doesn't only exist in our mind, but it exists between the doctor and all of our surrounding context. Because of that, the surrounding context can have great differences in how we make decisions. There's also, and Dr. Carrillo talked about this briefly, situated cognition. So there are cultural differences and individual differences in clinical reasoning that are unique to a cultural setting or even unique to an individual. A classic example might be hantavirus. I have never taken care of a case of hantavirus in my life. I'm a decent doctor. My hair is gray. I've been practicing medicine for a very long time. If I saw a case of hantavirus, even seeing the same information, I would probably miss the diagnosis because that is not something that I am situated to. It is not part of my medical understanding of the world. Similarly, in New England, we have a disease called anaplasma, so ehrlichiosis, which you may learn about but will never see in Chile. It's very similar to malaria and how it presents. When I first started practicing medicine, I see it all the time, but when new doctors come to New England, they are not thinking about this otherwise very common disease. Now, the other thing that I should say is the way that we study clinical reasoning traditionally has focused only on an individual. That is not the reality of clinical medicine. Medicine in the year 2024 is about teamwork, and not only with other clinicians, but with other healthcare providers, including our pharmacists, including our nurses, and other professionals. And what's very interesting is the way that we are taught clinical reasoning is, if anyone has been in a clinical reasoning case, you have all the information given to you. It's like a mystery. It's like a legal case. The reality, though, is that the information that we use to make decisions is spread out over time. Sometimes it's spread out over years, multiple different people. And I think this is part of the key. It's often mediated by technology in a way that it was not in the past. So chart review is something that is very important. And the key for me making a diagnosis may have been a test that was done in the medical record 2 years ago. So this is the idea of distributed cognition, that clinical reasoning does not only exist in a human's mind, it doesn't only exist in our environment, but it is about the collaboration of multiple people over different times and different places. All right, so those are our psychological theories that are up to date, right? This is our current psychological understanding of how humans make or how doctors make decisions. Why do we care? Dr. Carrillo talked about medical errors. Doctors make an unfortunately high number of diagnostic errors. This is from David Newman-Toker's most recent study. It was just published earlier this year. This is in the US, but 800,000 people die or are disabled because of misdiagnosis. The stat that he pulled out is 15 diseases account for half of all serious harms. The actual statistic is 4 diseases account for 40% of the harms. And these are diseases such as heart attacks. They're not difficult diseases to make. So misdiagnosis, it's not the like lupus nephritis that is being misdiagnosed, though I'm sure lupus nephritis is being misdiagnosed. It's acute MI. It's cancer that is being misdiagnosed. Diagnostic errors are very high stake. Now, one of the complaints to all the error literature is that, sure, there are diagnostic errors. Nobody says that there are not diagnostic errors, but are they because of the human mind? There are many systems issues that can cause diagnostic errors. This is a wonderful study by Andy Auerbach, a hospitalist. I think Dr. Carrillo knows him from the Home Run study, that looked at patients who were admitted to the hospital and they were correctly triaged. So they were not super sick patients. And then they got worse and went to the ICU. And they did a retrospective chart review. I was part of this study. And they found that defects in human cognition were by far the largest contributor, and that the number 2 issue was testing errors, which is another defect in human cognition. So we have known this for 20 or 30 years. It's just more information confirming that defects in human cognition are a large part of what drives diagnostic errors. Now, you might say this is great because we can improve human cognition. If we can identify that a large cause of human errors and harm is problem in decision making and cognition. Are there not things that we can do to make people better? And the answer has been, well, we hope so. So there have been 3 overall categories. This is what everyone in this room is doing. Everyone in this room is taking part in learning about human cognition. The 3 big strategies have been education about cognitive biases. So if you ever learn about anchoring bias or recency bias, the idea here is that by teaching you about these biases, we will improve your ability to identify biases in the future. Number 2 is de-biasing strategies. The most famous thing here is reflection. We know, for example, that one of the best ways we make doctors better is by having them follow up on their own patients and reflect about what went well or what didn't go well. And then the 3rd category is computers, artificial intelligence. Now, the unfortunate fact of this is that none, well, other than the 3rd, number 1 and number 2, even when they work experimentally, don't seem to work in the real world. And I think everybody knows the reason. It would be wonderful if we had a health system that allowed us time to reflect on how our patients did and to learn from that. Chile is very similar to the United States in this fashion. We see there is so much pressure to see more patients. When I am in clinic, I see a patient every 15 to 20 minutes. When I am in the hospital, I have to see between 15 and 20 patients. It is very difficult to carve out time. And in Chile, I think it is in the same as the US. After one of my patients discharges, unless I specifically seek them out, I very rarely learn about how they do. Now, this is different in my clinic. Being in the clinic keeps you very honest because you often learn exactly what you're good at and bad at. Of course, if you do a bad job, often the patients don't come back to you. So even in that, you don't get a lot of calibration here. So this brings us to artificial intelligence as a 3rd. As a reasoning researcher, one thing that I have to tell everybody here is that the study of AI is very old. There is a tendency, especially among people in Silicon Valley who want to make a lot of money, that AI is a new technology. This is actually the oldest quote that I have ever found about artificial intelligence. And if you look at the date, it's from the playwright, the English playwright Bernard Shaw in 1918. So he's talking about how when he was young, there were clerks who would do manual calculations. And that's all been changed by manual counting machines. So he writes, in the clinics and hospitals of the near future, we quite reasonably expect that the doctors will delegate all the preliminary work of diagnosis to machine operators as they now leave the taking of a temperature to a nurse, and with much more confidence in the accuracy of the report than they could place in the members of a Royal College of Physicians. The observation of symptoms is extremely fallible, depending on not only the personal condition of the doctor, who has quite possibly been dragged to the case by his night bell after an exhausting day. I definitely relate to that. But upon the replies of the patient to questions which are not always properly understood, and for lack of the necessary verbal skill could not be properly answered if they were understood. From such sources of error, machinery is free. So this is 1918, and Bernard Shaw is already identifying many of the factors that we would point to today that cause diagnostic errors. Now, historically, AI has been seen as a large solution, and I'll say historically from roughly the 1940s through 1992, and there were some very impressive AI systems historically. The most famous one is AAP Help, or the Leeds abdominal pain system. This was a computer-assisted system in the era before abdominal CTs that could make acute abdominal diagnoses better than any human. It was so effective that the U.S. Navy actually put it on all their nuclear submarines with the thought, this is the Cold War. So if a seaman developed an acute abdomen, they did not want to take the submarine out of commission unless they had to. So very effective AI algorithms. Now, from roughly the 1990s through the mid-2010s, there was basically no improvement in AI. There were some pretty cool programs. I did not take them very seriously as someone who studies clinical reasoning because they didn't really have, they were difficult to use. They didn't really have much impact in the real world. Now, all of this has changed in the last 2 years, and a lot of these lessons that we talked about in the 1970s and 1980s about how to work with computers are suddenly very important again because large language models are the most exciting intervention in clinical reasoning in decades. Before I go further for the students, if you have ever used ChatGPT, can you raise your hand? Yeah, that's what I thought. Everybody. Who has used ChatGPT in their medical studies, specifically? Yeah, almost everybody. This is what's going on with my medical students as well, and my residents. We're in a situation where the youth are the people who are the most advanced with some of these new technologies, and you're leaving us old folks like your professors behind. So I'm going to very briefly talk about how language models work and then why this matters for clinical reasoning. This is why I wanted to talk about the psychology of reasoning. So a language model is trained on virtually all available human text, all the internet, tons of pirated books. Basically, these companies scrub everything they can. And what they do is they split the text into pieces of words, tokens. That's a kind of basic unit of semantic meaning. And they're using an algorithm called a transformer, which very conveniently can understand and predict the next token in a string of tokens. Well, that's kind of how human speech works, right? We don't just have individual words. Words exist in sentences and paragraphs in order to have meaning. And then they put it through a very complicated training process. There's a pre-training where they give good inputs and good outputs. And then there is a fine-tuning process called reinforcement learning by human feedback, where they actually sit down human beings to look at good inputs and good outputs. And if the computer says, if the algorithm says something good, they basically give it a thumbs up or a cookie. If it says something bad, they give it a shock. It's a Skinner box for training an AI model. And what ends up happening, this is a Star Trek reference here, but what ends up happening is that it is able to create human speech that is remarkably human-like. If anyone, well, it sounds like everyone has communicated with these algorithms, they're very good in Spanish. Unfortunately, they're not as good in every language, but they're really good in English, they're really good in Spanish, and they're really good in Chinese. And they're pretty good in other languages. But it's like talking sometimes to a human being. And I should say, I did do this so I could do a Star Trek reference, but this same technology to predict tokens, these transformers, can be used for virtually any type of creative output. I'm sure all of you have created images with AI. Now you can create videos. You can clone people's voices. I showed Dr. Carrillo a video of a fake patient, a synthetic patient that was fully powered by AI that you could talk to, that you could communicate with. So these technologies are advancing very rapidly. But here's the question. Why does this matter for clinical reasoning? Why should a system that can predict the next word, basically like, in Google, when you predict the next word for Google, why does that help us make diagnoses? So I'm going to share with you a real case that I made a diagnostic error in, and the patient died. So this was a middle-aged man who presented with months of night sweats, dramatic monocytosis, daily fevers, quotidian fevers. He had ground glass opacities on the x-ray. He had a history of BCG. So what is BCG is the treatment for bladder cancer. It's the old-fashioned tuberculosis vaccine. He did not get any better with antibiotics. His liver enzymes were elevated, and he had a history of spinal surgery. And this is a gentleman who I made a diagnosis in. I diagnosed him with endocarditis, culture-negative endocarditis, and he died. And 6 weeks later, this also happened to be in February of 2023, I got a result back from the state laboratory that told me that I was wrong. I was completely wrong about what he died from. He actually died from Mycobacterium bovis bacteremia. Very rare, very difficult diagnosis. I felt terrible. His wife was actually a nurse at the hospital. So obviously I was devastated not only by the fact that my patient died, but that I had made a misdiagnosis. But what really upset me is this was day 2 that GPT-4 had been released. And I pulled up one of my old notes, and I put that note into GPT-4, my thoughts at the time. And what did GPT-4 tell me? It told me that the most likely diagnosis was a mycobacterial disease, and the second most likely diagnosis was culture-negative endocarditis. If I had had this technology just 2 months before, 3 months before, he may still have died, but I don't think I would have made that misdiagnosis. So the reason that LLMs appear to be able to make diagnoses, and I can talk about this more in the evidence, is that the way that we, human clinicians, make diagnoses is semantic clustering. It's illness scripts. We use language, and in this time it's language encoded in our brains, to make these diagnoses and to do system one thinking. An LLM is effectively able to do system one thinking at scale in a way that does not get angry, in a way that does not get tired. It doesn't need coffee to fuel itself. It doesn't get in a fight with its wife prior to coming to work, and it is always efficient. So, as a researcher, my research is in human-computer interaction. The question is, how can we actually make, an LLM cannot take care of patients. So there are people in Silicon Valley who will say we don't need doctors anymore. I think everyone here knows that is ridiculous. We need doctors. Doctors are always going, well, until every single job has been replaced by AI, we are going to need doctors. So the question becomes, how can we use these technologies to make us better at our jobs to better care for our patients? My opinion, and what a lot of my research on, is second opinions. There is reason to think, these are from human second opinions, that just getting a second opinion can drastically improve clinician performance. Depending on the site, second opinions can change the diagnosis between 1.3% and a third of the time. There was one review in Pakistan where a second opinion changed the diagnosis a third of the time. The best study is actually in the Netherlands and at Utrecht, where a new diagnosis was only found 13% of the time, but a new treatment was offered 56% of the time, and patients felt better almost a third of the time. So there's reason to think that second opinions are very effective. So LLMs encode a massive amount of knowledge. If you were to give an LLM a standardized test right now, it would pass above the level that any human doctor could even possibly imagine. They also are able to communicate with patients more empathetically than humans. This is actually what some of my own research has shown, which is quite depressing for humans. But patients, in many senses, it's only mediated via text, but they prefer talking to LLMs than talking to human doctors. They can make diagnoses. As we demonstrated here, an LLM at this point is capable of making a diagnosis far more accurately than any human clinician. And the latest models, the model that I just showed you is O1. I can talk a little bit after if anyone wants to talk about it. It uses something called internalized chain of thought reasoning. It can solve a New England Journal CPC at about a 90% accuracy. In comparison, humans can solve that. The best humans can solve it about 20% of the time. So it shows superhuman abilities in solving cases. Now, they also have as you could see, a really remarkable sense of probabilistic reasoning, which doesn't make sense because they're only predicting text. But this is a study that I ran. LLMs have a more probabilistic understanding of the world than humans do. That is, they have a better understanding of the pretest probability of disease and how different diagnostic tests change that probability. Now, it is not perfect. It is not an epidemiological understanding because, again, they do not experience the real world, but I'm going to do air quotes, their intuition is far superior to humans. They can forecast diagnoses, and this is based on old data. This is a study that's way out of date now, but they are able to say with much more accuracy than humans what the most likely diagnosis is. And they can show clinical reasoning. This is very important for when we think about how we're going to implement these things to make humans better. They are able to display human reasoning. In this image, the red is the computer, the green is attending physicians, and the blue is residents. So as you can see, attending physicians display reasoning better than residents, but the computer far outpaces both of them. And without any loss in efficiency, accuracy, or cannot miss diagnoses, though they do what's called hallucinate. They make up information, which is concerning if you think about how high stakes medicine is. And I think anyone who's used ChatGPT is familiar with the concept of a hallucination. Now, this gets to my research. One of my questions is, how do we make people better? Because, to stress again, no AI is going to be taking care of patients. Human doctors are going to take care of patients. So the question is, how do we make humans better? This is a study from Google that caused a lot of consternation in my field, because what it showed is that humans by themselves did the worst. Humans doing Google search did a little bit better. Humans doing the AI did better, but the AI itself did the best. And this flies in the face of the traditional axiom of informatics, which is that the human plus computer will always do better than computer alone. Unfortunately, this study will be published in JAMA in 2 weeks. I ran a randomized controlled trial that showed the same thing. We took a very powerful AI system and randomized doctors to either use it or not in solving difficult cases. And you can see in the red, the AI system drastically outperformed humans. The green over there is humans plus the computer. There was no difference in the humans using the AI between the humans alone. And the reason, as we dug very deep into the data, is that humans loved the AI when it agreed with them. When the AI disagreed with them, they just disregarded the information. we did another randomized control trial on management decisions. So Dr. Carrillo talked a little bit about management reasoning, which I have not talked about. Management reasoning is very complex. And you would not think that an LLM could do management reasoning, because how could it understand the context of your patient? Now, this study did show that the LLM made humans better at management reasoning. But when we did a subgroup analysis of the data, the reason was quite depressing. The AI was not actually better at saying you should get this antibiotic. No, humans did a better job at this. The AI was better at cueing humans to, for example, apologize when you make a medical error. It was better at cueing humans to make sure to communicate well with their colleagues or to take patient factors into consideration when working up a lung nodule. In other words, we have these things that we imagine humans are good at and computers are good at. And the computer actually made humans better at the things that we all should be good at already. So it was a very disheartening piece of information. And then this study is what I'm a visiting professor at Google as well. This is a study from my group that LLMs are actually able to take a history. Now, mind you, it is via text, but they're able to take a history from patients better than humans when you do a true blinded trial, a Turing test. The LLM actually takes a better history than human beings do. So another thing that I would think humans are uniquely good at, the computers also show an ability to do. We're now starting to see the same information when it comes from EHR data. LLMs are able to extract information from the EHR live and make diagnoses. I actually have a system running in my hospital right now where for patients in the emergency room, we're providing live second opinions to the emergency room doctors and the internists caring for them in the emergency room. Now, they cannot make autonomous decisions. This was published in Nature Medicine not too long ago. An LLM, when you try to when it has to make a definitive decision, it doesn't do particularly well. This just gets to what I'm saying about. We're not at a point, and I don't think we'll ever be at a point that the LLMs can practice medicine. So the question has to be, how do we work with them? And I'll skip these. And then something that is quite concerning in our field is the biases that are in LLMs. This probably gets to why LLMs can perform well on their own but don't perform as well with humans, is they encode all of our own biases. There are some studies that show that LLMs also have recency bias. So you can imagine that if a human has recency bias and they use an LLM, they may just use the LLM to confirm their opinion rather than challenge them or change their opinion. They also have ethnic and racial biases encoded in them. So they have the same biases that we as a society has reflected in their outputs, which you can imagine is very concerning if we're worried about how human bias affects our patients and we have a computer system that has those same biases in it. It could make things considerably worse. So my research, and then I will end, is not so much about building models. I do some work with models and for oversight of reasoning, but really my research is about how do we make humans better? What factors are necessary to make these technologies work well with humans? We don't have a good answer thus far. At this point, most of our interventions have not worked very well, even though the technology is capable of outperforming humans. So there are this is a brand new field, and there are a lot of open questions. And then one of the things that I worry about, because I am a medical educator, all of the medical students here, it sounds like everyone uses LLMs. At my medical school at Harvard, most of my medical students use LLMs. One of the questions that I have is, we know that in order to train doctors, we need to learn to use our brains. And learning to use our brains is not fun. It requires us being wrong. It requires us making guesses. It requires us, unfortunately, doing the wrong thing to our patients and then getting feedback so we can train our brains. Everyone saw how effective that O1 was at making that PJP diagnosis. This patient was seen by some of the smartest doctors at Harvard who did not make that diagnosis, but O1 did. How are we going to train a new generation of doctors when right now any one of you can go online for free and use this technology? I don't know the answer to that. I think this is a unique challenge in medical education. I think this is a very exciting and also very scary time to be studying clinical